He also was the co-editor with Herman of a book on exercise training, exercise testing and training in coronary artery disease, which was published in 1973. Dr. Norton's topic is an appraisal of the National Exercise and Heart Disease Program.
studies, and that they came in after their infarction had been healed and had recovered. And of course, most of them were ambulatory. All of them were ambulatory, and therefore they're a pretty well-healed population in that regard. They're already back to doing normal life function. So they're a little bit at lower risk than if you took the population right out of the hospital setting, but not that much so. All the subjects had a baseline exercise test designed to take them to some definitive point of limitation, either symptoms or abnormal signs, or reaching the age-predicted heart rate level for their age in the absence of symptoms or signs. And then they were followed periodically, which the test was repeated in the same way in all subjects. Those randomized eventually to exercise were obviously followed in a long-term training program under close supervision, and those that were randomized control group were given no advice about exercise and discouraged to not exercise. Now, the first set of information that I'll show will be limited to the observations that we obtained from the baseline test. Obviously, we were able to evaluate certain parameters of performance. We were able to look at predictors of subsequent mortality over the period of the trial, 3 years, from the data found in the exercise test. And we were also able to do some analyses of what happened to blood pressure related to normal people, heart rate, so on and so forth. And then after we go through that, I'll go into the effects of the training on the group as well. So here we have the distribution of endpoints in the baseline test. And you notice that of these 651 subjects, 2/3 of them stopped the test because of symptom limitation. Symptoms were 5 in nature in terms of major symptoms: chest pain, shortness of breath, fatigue, claudication, and a subjective sense that the subjects could not proceed any further. 1/6 stopped because of sign limitation. In other words, EKG changes or some physical observation that warranted stopping the procedure. And another 1/6 were able to reach the age-predicted heart rate level without any abnormality. And for those of you who have been involved in work performance and exercise, if you read into the slide, you should be able to project that the subjects represented in the first 2 columns are the ones with probably the greater number of abnormal findings, and the one on the far right-hand column, the least limited patients. Well, before we go there, systolic blood pressure response, a high heart rate response, or LSD change, had not only a much more significantly lower mortality over 3 years than the other groups, but the mortalities are really down in the range of about 1 to 2% per annum. So they really are a favored group. Now, to refine the analysis, we went to multivariate analysis and to see whether those variables did have a relationship to mortality over the 3-year period of study. And indeed, 3 of them held up very nicely. You notice that 1 does not, namely heart rate. And in this case, a hierarchy developed. There was a 3-fold mortality rate over the 3 years for those patients with a work capacity level below 6 meds. There was a 2.5-fold increase in mortality for the subjects with less than 140 millimeter mercury pressure generated during exercise. And there was a 2-fold mortality for the subjects with ST depression indicating ischemia during the exercise procedures. When we look at the mortality outcomes in this way, we look at those that were symptom limited. That was 447 of the 651 patients. Those who were sign limited, and those who were able to reach the heart rate limit in the absence of signs or symptoms. We see that there's a higher mortality in the symptom limited subjects than in either the sign limited or the heart rate. And it's interesting that the difference between the sign limited subjects and heart rate limited subjects was not statistically different, 4.6 versus 4.2%. But symptom limitation obviously varies, but also bad prognostic outcome. And the difference between 6.7 and the 4.6 and 4.2 is statistically significant. The overall mortality for these subjects over the 3-year period was 39 subjects for 6%. Now, in looking at some of these sub-areas, we can look at systolic blood pressure outcomes from that. And this is data from a normal population of middle-aged men, ranging in age from 20 to 59. And you notice that regardless of whether you're looking at the younger subjects or the older subjects, 20 or 29-year-old group versus the 50 or 59-year-old group, or the total group, 20 to 59, with the total group being about 313 subjects, that in all cases, in age, the blood pressure during exercise increases until it reaches the maximum. And that the younger subjects have a lower increase in blood pressure than do older subjects, but this reflects the finding that we know at rest that older subjects tend to have a higher systolic blood pressure than do younger subjects. And so obviously one would say that this is indirect evidence that in healthy subjects, systolic pressure is increasing and therefore cardiac output is as well, and that reflects a healthy myocardial status and cardiovascular status. When one looks at the 651 NEHDP subjects, we find something a little different. Namely that those subjects who enjoy a good capacity level, in other words 7 to 9 meds or greater than 10 meds, have the response that is customarily seen in healthy subjects. Namely, the blood pressure increases with age, and if you can do more work, then you should have a higher peak systolic blood pressure. Obviously, not very many cardiac patients can exceed 10 meds, and that's why we don't have a mark for the 60 to 64-year-old group. There were enough subjects in that subgroup to analyze it. But if we look at the subjects who are limited, those under 6 meds, you notice that regardless of age, the peak systolic pressure ranges from about 155 to about 158 millimeters of mercury. And so these more limited subjects have a more distorted systolic blood pressure response, in part because they have a low threshold for work, but probably in part because they have more myocardial restriction and problem with contractile state and so on and so forth. The mean data seems to bear this out a bit, in that if we look at the mean peak systolic blood pressure response adjusted for age for all the subjects and go from age 30 to age 60, you notice that except for the youngest part of the subject group, right here, if we had taken this off the slide and just stuck with the 35 to 60-year-old group, that the peak systolic pressure is pretty flat. In other words, as a group, people with field myocardial infarction do not enjoy the same kind of systolic pressure response that patients or higher in the younger subjects and decrements with age, reaching values of about 135 plus or minus a few beats at age 60. And the decline is fairly steady over that period of years. The thing that's different is that these peak heart rate values are probably on the order of 15% lower than we see in healthy subjects at the same age. And again, if one looks at the outcome in terms of mortality over the 3 years, you notice that the mortality rate in subjects with a low peak heart rate response is much higher than in those subjects who reach the 85% level or the 100% age-predicted heart rate level. In this case, it was 8% versus 4.3 and 4.2. And again, you notice that in the patients who reach 85% or 100%, the mortality rate is almost identical. Raises a question that's not been explored by us or answered, and that is there a need really then to push patients to 100% if your only question is outcome of mortality? I don't know the answer to that, but that's left for someone to study. Obviously, the patients with the lower than 85% heart rate also fall in the category of those that are mostly symptom limited. So you get some crossover in these two variables that we'll explore later. Now, there's been a lot of interest in relating the finding of a low peak heart rate to subsequent mortality. And as I showed you in the univariate analysis, there is a relationship. But if you do multivariate analysis, that relationship tends to break down. Bob Bruce in the late 60s, early 70s described the concept of heart rate impairment, which was defined as the difference between the heart rate level that a cardiac patient reached in comparison to what he should reach if he were healthy and unlimited. And we again looked at that finding in relation to age, going from age 30 to 64, looking at by decades as much as we could. And you notice that in the younger patients, there was a 15% lower peak heart rate than one would anticipate. In the middle-aged group from 40 to 59, that was about 18%. And in the group over 60, again, that was closer to 15%. This indicated that the finding of heart rate impairment was not age-related, as is the decrement in heart rate, but probably disease-related. And to follow that down this step, we looked at it from the following analytical point of view. In taking the 555 subjects who were either symptomatically or sign limited, those who could reach the age-predicted heart rate level, and then looking at those who had low work capacity versus high, and you notice that the degree of heart rate impairment is related to the degree of compromise in the cardiovascular system, namely those with low work capacity and almost 25% impairment in reduction of peak heart rate level, whereas those who enjoyed a high capacity, that fell down to about 12% and below the 15 or 16% that the total group witnessed. Now, and again, in analyzing the relationship of heart rate and work capacity to prognosis, we looked at those who had low capacity, less than 6 minutes, versus high, greater than 7 minutes. Those with a low peak heart rate response versus those with high, and the same over here. And you notice, rather interestingly, that it's obvious that if you have a low work capacity, that your prognosis is going to be much poorer than if you have a high work capacity. And that the relationship of peak heart rate is not particularly important. And in fact, the low work capacity subjects with a low peak heart rate response, a high peak heart rate response, had a little worse prognosis than did those with a low heart rate response. And once again, that is not too surprising if you think about it physiologically, because the normal response to low thresholds of exercise is to have a low heart rate, whereas high heart rate with low workload, you probably have more myocardial dysfunction to deal with. You notice that in the case of high work capacity, it really didn't matter whether you reached 85% or greater. The prognosis is very good, and the mortality per annum is down in that 1 to 2% range, whereas here we're talking about per annum mortalities of 4 to 5%. This just reflects what we found when we looked at peak heart rate response in these subjects in relation to the threshold of work capacity, both low, intermediate, and high. And the curve, as you see, is very much as you can see in the stayed steady through the first year and then began to decline during the second year. Notice that in the control group, there's a slight blip in the first 2 months. This steadies off during the course of the year, and just as in the treatment group, it falls down during the second year. The difference in capacity measurements were statistically significant at three points during the first year of observation. It did not stay significantly different during the second year, but you can see that the training group still enjoyed a slightly higher capacity than did the control group. So one of the outcomes of whether training works or is different than in control subjects was confirmed. Namely, the training subjects did have an increase in work capacity, and they did have other changes that we know relate to training that didn't occur in the control group. Now, Overman looked at effects at 1 year on some outcomes, and in this particular slide, we're looking mainly at those kind of risk factors that people are interested in. We looked at work capacity, percent of body fat, what happens to cigarette smoking over the course of that first year, resting systolic and diastolic blood pressure, and then lipid parameters. The pluses indicated an increase and the minuses a decrease. The plus minus indicates essentially no change. You notice that just as the previous slide reflected, work capacity increased in the exercise group and went down in the control group. And at the end of the year, the differences were statistically significant. Body fat went down in the exercise group, went up in the control group, again reaching statistically significant differences. And this occurred despite the fact that both groups gained about 5 pounds of weight. Cigarette smoking did not change appreciably. It was not affected by the training program. And excuse me, there was no significant difference in the number of smokers between groups at entry or at 1 year. And there was a slight increase in the number of cigarette smokers in both groups during that year. Systolic pressure went up a tad in the training group at rest, more so in the control group, but those values were not statistically different. Diastolic pressure did go down in the treatment group, stayed about the same in the control group, but the differences achieved significance. And in terms of lipids, cholesterol, LDL, and HDL, each went up slightly in the treatment group, more so for cholesterol and LDL in the control group. Essentially no change here for HDL, but none of these were statistically different. Whereas triglycerides dropped appreciably in the control group, went up in the treatment group, went up in the control group, and reached statistical significant difference. So we could say that the training apparently affected 4 variables significantly and did not affect 4 others: work capacity, body fat composition, diastolic blood pressure at rest, and plasma triglycerides in the fasting state, whereas the other 4 variables were not affected at all. Now, one of the things that one would be curious about, since we have the data that we looked at relating to prognosis, is if you have a marker of poor prognosis, are you refractory to the training process or not? And this slide is busy, but it's not as complicated as it looks. We looked at the degree of ST segment depression in both training and untraining subjects, peak systolic blood pressure on the baseline test, and work capacity level achieved. The solid open bars represent the control subjects, and the dashed bars represent those that were assigned to exercise. The figure in parentheses represents the change in mortality over the 3 years in those subject groups. You notice if we take the bar we set here and say, okay, now which subjects got ST segment depression, how many were assigned to control, how many were assigned to treatment, and then what was the mortality rate over the 3 years. You notice that there's a higher mortality in the control subjects with the ST segment depression at baseline testing than in the treatment subjects. And the percent reduction of mortality was 37% in this particular subgroup. Now, the overall reduction of mortality in the National Exercise Heart Disease Project was 37%. So I was right on the target with that. Take the subjects who did not have ST segment depression and ask the same question. You notice that the reduction of mortality is 46%, slightly greater than the 37% in those who had the finding. But this difference and this difference, these two numbers are not statistically significantly different from one another. We go over to the far right-hand side of the slide and look at work capacity, those with low versus those with high at baseline. You see that there is a 26% reduction in those with lower capacity who were in the training program, and a 55% reduction in those with high capacity who were in the training program. Even though these numbers numbers are widely different, 55 versus 26. They did not achieve statistically significant difference. And of course, that's because this subgroup is not very large. In terms of blood pressure response, we find something a little different. Namely, in those with a low peak systolic blood pressure, there actually is a slight excess mortality in those who are entered into the treatment program. This is actually, I think, one more death, 8% increase in the treatment group than in the control group. On the other hand, those with a high peak systolic blood pressure response had a 69% reduction in mortality. This difference is statistically significantly different and indicates that this particular subgroup benefited a good deal from the training program. Now, this raises an interesting question for future study, and that is this a group of subjects that should not be referred to training since they didn't benefit, and since there is a slight additional risk of mortality in those assigned to treatment than not? And clearly, this is probably the group that has a more serious underlying myocardial disease, although we've been able to evaluate that because we didn't do any invasive or invasive studies to determine that outcome. But clearly, this is a very important finding, I think, of the NHDP, as are the others, because the other findings indicate that even though you're at greater risk of mortality over 3 years, and you may not do as well with training from a quality of life point of view, you still tend to benefit to almost the same degree as those that don't have the finding have. And I think this is worth further exploration as other studies are done. Lastly, the effects on the total group. You notice that at every point over the 3 years, mortality is lower in the treatment group than in the control group. As I say, the reduction in overall mortality was 37%. There were 14 deaths versus 25 deaths, treatment versus control. And regrettably, the findings did not reach statistical significance, reached a p-value of 0.22, which from a strict scientific point of view leaves us with a little dilemma that exercise looks as though it's effective, but clearly we can't make a statement saying that it does prolong life or reduce mortality substantially in myocardial infarction patients. And part of that is a result not of the design of the study or the character of the intervention, but unfortunately limitations that occurred from the funding of the program. We were able to fund and support a study of 651 subjects, and in the final analysis, it looks as though we could have determined the outcome if we had a sample size of around 1,400 patients. It's probably an opportunity missed from a public health point of view, and it will leave all of us long-term trying to answer the question that Herman originally asked many, many years ago about the effects of training on reducing mortality. I thank him and our co-investigators. I thank him for his help in putting the study together and for his cooperation in following protocol to the letter of the law. This center had best quality control of all the centers, and clearly I think it's a major contribution that will be important in medicine for years to come. Thank you very much.
Was it surprising or perhaps disappointing that there seemed to be no difference between with respect to smoking cessation? And because one of the reasons for post-MI rehab is sort of the hygienic effect that they have on those sorts of bad habits.
Well, I would say we have done a poll of all the investigators, but I would say yes, it was disappointing in the sense that we all were hopeful that as a secondary outcome of the trial, a lot of quality of life factors would have been affected. But I think that in a way it also wasn't surprising because there was no evidence to show that exercise training by itself reduces smoking habits. And it indicates that if you're serious in dealing with other risk factors, then you got to have a multi-purpose kind of trial. One that as clinicians we all would like to have had, but we wouldn't have been able to do the study then because we've had too many variables. And for example, the only trial that I'm aware of that so far has come out with any indication that exercise maybe offers significant differences is the Finnish trial, Leo et al. But unfortunately, that's a multivariable trial. And you can't answer the question there, was it the exercise, was it smoking, or was it dietary counseling? So we did not want to get ourselves in that predicament, and we did not want to get ourselves in the predicament of Murphy, which are left not being able to make a pretty good conclusion. The one thing that was very impressive about this trial at the end was that the two groups remained exception of interventional exercise during the 3 years. For example, in both groups there were about 15 bypass surgeries. In both groups there were the same number of rehospitalizations for all events. That also surprised us that morbidity in that sense was not affected. Now, not all those rehospitalizations were recurrent in mind. There were a lot of conditions, but the same number of rehospitalizations occurred in both groups over the 3-year period. The subjective sense of the investigators at our final meeting before going to press with the initial paper was that they all felt that the rapport that was established with families and patients had an effect on outcome. The data clearly showed it had no effect on outcome. Very disappointing to them, but it's sort of missing gain that we played at the end of the trial. And I think the other thing that was shown is, for Herman's benefit, how important good biostatistics and epidemiologists are, because they did a very good job on keeping us honest, keeping the data blinded, having it centralized, and not letting us in on the outcomes until the time was there. We had a terrible problem with the agency in that regard, but I can tell you that the Ontario study failed because they did not have that in place, and the end result is they came up with nothing from a scientific point of view. So I think from a design study point of view, this is a very beautiful study that we're very proud of architecturally. We're just disappointed that we didn't get the final answer at that point.
Of patients who went through the study completely, did compliance with the exercise regime change during the program, or were those dips that you showed us due to other things? So,
Compliance and adherence, of course, changed over time, and we kept track of that, but our design was not created to look at compliance very scientifically, so we haven't done anything specific with that data yet. The interesting thing about compliance number 1 was the high degree of compliance that we had. Most exercise trials have had the experience in the first year of dropouts of 50% or greater. At the end of the 3 years, we still had 67% compliance. Now, because this trial is more complicated, I've given a different definition of compliance than you would adherence. For instance, if you're attending one session a week and you're in the training group, you're complying, but you're not adhering to the frequency that one wants. So if you take compliance, you may get a little higher compliance figure than you would a sub-adherence figure. The follow-up on these subjects at the end, we do 100%. So all deaths were accounted for. And that's a major difference between us and the Ontario study. Whereas their dropout rate went along, they simply stopped following those patients who dropped out. So we know who died and who had more events. And we had a subgroup of people looking at the death certificates and outcomes. So we had verification of what the deaths were. So I think that part was done very well. But 67% compliance for 3 years we thought was quite good. Did decrement over that period of time. Obviously we had some dilution in that some of the training subjects became sedentary and some of the control subjects became active. We tried vigorously as we could with an ethical balance not to let the control subjects get contaminated, but they had lots of access to opportunities. But still, I think one lesson, not scientifically confirmed but observationally valid, is that if you're assigned to a control group, at least in an exercise program, you're more likely to be sedentary. They don't voluntarily, as a large group, become active. So if you're asking the question, is it worthwhile having these programs, which is being asked by carriers and community groups now we're in cost containment and so on and so forth. It's clear that if you think exercise is valuable, you got to have a program. You got to tell people to do it.
Thank you very much. I think we'll want that. Professor of Psychiatry at Harvard University and Massachusetts General Hospital. He's on the Scientific Council of Cardiac Rehabilitation of the International Society for Cardiology, and Herman reassures me that he is a practical psychiatrist. His topic is psychological aspects of post-myocardial infarction rehabilitation. Dr. Hagen.
I'm
I'm not quite sure what a practical psychiatrist is. I'm prepared to fix fixtures or fix the furniture or help in any way that I can. I'm also very pleased and honored to be here. I have known Herman since 1970, and I was trying to think about the first time I met him, since we've all been talking about our first encounters. And suddenly it came to me very clearly. It was in Springfield, Illinois in 1970. We were both scheduled to give an after-dinner presentation. And the audience, after, there were about 300 of them, and postprandially they were in just deep slumber. I gave my talk and put them further to sleep. And when I finished, there was no applause, nothing but deep breathing. And I thought, my God, Herman was next. He got up, he jumped up on the podium and said, okay, up on your feet, let's run in place. And they all did. Ran in place. And I thought to myself, my God, he is a live one. I've been saying that ever since. Later on, that same evening, we talked for a while. Then I saw him in the parking lot. This was at midnight. And he got into, I think, a rented car. And began zooming off. And I waved him down. I said, where are you going? And he said, back to Cleveland for rounds tomorrow morning. And off he went in the middle of the night. So that was my introduction to him. He is a live one. I think he's a creative and a moving force in medicine. I have learned a great deal from him, and much of the work we've done at the Mass General on the cardiac patient has been influenced greatly by his contributions and by his counsel. I thought it would be fitting on this occasion just to briefly summarize some of the research that we've done up there. And to do that, I think if we divide the MI experience into three parts, into the pre-hospital phase, the hospital phase, and the post-hospital or convalescent phase, you'll have a very easy access to our research. Each of these particular phases has their own psychological problem. And I begin with the problem of the pre-hospital phase. And this is the interesting problem of delay. Why do people, when they experience sudden chest pain, reach for a Brioski instead of coming into the hospital? And the majority of them do. A group of us at the hospital, published a paper in 1969 on delay in MIs. And at the same time our work came out, two other studies came out. And all of these studies, most unusually, had the same findings. And that was, there was a delay of between 4 to 6 hours following the onset of pain before the individual got into the hospital. Now, the majority of that time, hours of it, was taken up with decision making, not with traffic or anything else. Once the person had decided to get to the hospital, he was usually there within 11 to 16 minutes. The interesting thing about delay, of course, was that you certainly want to reduce it because of the life-saving measures that can be carried out in the emergency ward. But the fact of the matter remains that these individuals, despite the fact that many of them had MIs before, persisted in their pattern of delay on the second and third attacks. Usually what they did was to rationalize it. They would displace the symptom by saying it's indigestion. Or it can't be happening again, or I'm too young, or this is much too small pain. They would go through a whole series of mental gyrations in order to avoid confronting the issue of being left behind. We found, for example, that it was the same in males or in females. The delay was the same. There was no difference age-wise. Young and old delayed to the same extent. Educated versus non-educated were the same. Cardiologists, the same as non-cardiologists. As I mentioned, the history of MI did not guarantee the person would come any sooner whatsoever, and there was often a pattern of delay that was familial. The father would delay, and one found that his son would delay almost to the same extent. The degree of pain we felt made a difference, pain being the great persuader. The more the pain bothered the person, the more rapidly they would respond. No go. Up to a certain point, if the pain was excruciating and stopped the person from doing anything, he was likely to be brought to the hospital by a cohort, a confederate, a wife, a spouse. But pain in itself was not the persuader we had hoped. Dyspnea, again, we thought that would be something that would drive people to the hospital. It didn't make very much difference. All of the factors that seemed to help, it was the presence of someone there with the person who could act as an auxiliary reality tester, like a spouse or a nurse at the plant, or somebody there, or a policeman, for example, on the street. Somebody who could say, you go to the hospital, that would make a difference.
set up a panel, a task force on decreasing delay times. I was part of that. And I think the essence of that, our problem, had to do with an experience that one of the people on the committee, or the panel, had. He was a cardiologist, my age and very good health, and he was driving across the desert. He came from the West Coast to a meeting, and on the way he was alone. He had a sudden pain, substernal, that went up into his shoulder, left shoulder, and he said, hiatus hernia. And then he said, now if I do what Hackett says, I'll stop and get a Briosky, which is a bad idea. So he pulled over, went to the drugstore, got an Alka-Seltzer, and it didn't help very much. So he called his nurse back at his hometown, and the nurse, who knew him very well, said, why are you calling? He said, well, I just had a pain in my chest, and I thought I'd stop and get an antacid. And she said, where's the pain? He told her, and she said, you go to this hospital immediately. I'm calling Dr. So-and-so, and he will meet you there in the doctor's parking lot with a gurney. You're going to follow your own advice and go there. Furthermore, I'm calling the state police with your license number, and they will stop you. So he went to the hospital. He knew that she would. Got out. The doctor was there. He got on the gurney, was admitted, and was infuriated. They drew bloods. He had a little bit of an SGOT that went up slightly. He spent the weekend there and insisted on Sunday that he have a barium swallow. They did a barium swallow, of course. The rest of the EKG came back, and he had a hiatus hernia. Now, he told that story as a joke, but the fact remains, here's a guy who not only is he a cardiologist, but he's been working on this committee for a year on delay, on patient delay. If he delays, what chance do we have? So we switched our attention from the patient to the HelpMate program, or the HeartMate program, as some of you may know. All of our educational efforts were switched to those who were with the patient when they had the chest pain. And the information we passed out was very simple. If the pain that you have stops you from doing what you're doing, severe enough to stop you, if it lasts for 2.5 minutes minimum, then the person you're with who's having the pain should be taken to a hospital. Now, I don't know if that made any difference at all. I'm not at all sure that the delay times have reduced, because the program we set up to demonstrate this in Orange County was squashed sometime after it got started by government cutbacks. But I think at least that it has the chance. We also said we followed the advice of Mamie Eisenhower. As you know, she was the person who alerted Ike's doctor when he had his heart attack in the summer White House. He said that his chest pain was due to a Bermuda onion that he had. He happened to be with General Bradley, who was playing golf with him the day that he had his chest pain. And Bradley said, I have chest pain too, and the same onion. And he delayed calling, or Eisenhower did, until Mamie insisted that he call at night. And the doctor, as you may remember, Dr. Snyder, said that agreed that it was indigestion. And it wasn't until the next day that he did an ECG and admitted that it was an MI. So I think Mamie was a great help in getting Ike in, and we, again, turned all of our attention to, one, educating the individual who's with the patient who's having the pain, and also anticipating that the first response of the patient is going to be to deny the significance of it, to look for reasons to explain why this pain is there and why it isn't an MI. And also, I think, to point out to the individual, and this has been done, I think, in the last few years, that it is worthwhile taking action, because having an MI does not immediately put the individual into the category of a cardiac cripple, which was a fear of some years back. Now, we next turn our attention to what happened when the person came into the hospital. What is the experience of the individual once he gets into the hospital? In the emergency ward, usually what happens is he is comforted by the fact that he's taken seriously. That is, there's a line put in, he is bypassed by the desk, he's taken into an examining room. The whole procedure of the initial workup, having the ECG, for the most part, a reassuring event for the patient. There are some complications sometimes, particularly in Catholic hospitals. Extreme unction is given in the emergency ward, which probably isn't the best thing. Although we did a study some time back on that and found that it wasn't nearly as bad as one would think, as long as the priest who gave it was comfortable and wasn't scared and knew how to be in the presence of someone who was vitally ill without getting frightened himself. The critical variable was the priest and his manner. For a long time, we had a fellow who looked like Barry Fitzgerald who'd come in with his bag and he'd say, what do you think of the Red Sox? Or he'd begin to talk about something that would be disarming to the patient. He'd say, by the way, I've got these ointments with me. We can say a few prayers together. If you want to, you don't want to, you don't have to. And he'd comfort the person. They'd say, sure, put them on. We'll say a prayer together. He went on vacation. And the new fellow who took his place had no training whatsoever. The first call that he had, I happened to be there. He came in, he was playing tennis, and he put his cassock on over his tennis shoes. So he came in wearing a cassock and tennis shoes and carrying a bag in his panty. He said, oh. He said, I'm sorry, I said, I came over as soon as I could. And the fellow said, why did you hurry? He says, he said, with a ticker like yours, you can pass out in no time. That was no way to do it, obviously. But once he was straightened out, even that rather arduous exercise, the giving of extreme unction, wasn't so bad. I began work in the coronary care unit thinking that the apparatus of intensive care, monitoring, defibrillating, constant vital sign taking, would frighten patients. Particularly some of the old-fashioned monitor pacers that were in vogue, the electrodyne equipment that made a noise like a klaxon. It was like Berlin, 1945, whoop, 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 and that one. And predicted that people who had to undergo this would be made worse. I mean, literally, they would be made delirious. The fact of the matter is, the way the machinery was introduced, the way the person was introduced to the coronary care unit made all the difference. They had one-to-one nursing for the most part, which, I mean, if you had one-to-one nursing, you could be taken care of in a cold bed, and you probably wouldn't mind. But the nurse in this particular case introduced the monitor as a mechanical guardian angel. And she said this was working with largely an Irish Catholic population. With this attached to you, you couldn't die. If someone shot you in the head, you still wouldn't die. Forever. And they took that literally and we found that it was hard to wean them from the monitor. They were nervous being taken away. We also found for the most part that the mood of these patients, although anxious, most of them, 80%, were anxious. There was very little in the way of extreme anxiety or panic states. One did not see that. Over the course of time, we have had deliriums in the ICU, and some of them have been devastating. And we found, particularly recently, that the use of intravenous haloperidol is probably as good as anything. We've given sometimes as much as 500 milligrams in the course of a day for extreme delirium. So I pass that along to you. For the most part, we sedate people, however, with benzodiazepines, usually mandatory, saying to them that we would prefer them to be sedated than not to be, and not put it on a PRN basis because they won't ask for it. There have been some studies that would indicate that mild sedation lowers mortality. We've not taken a head count on that. I think most people, the majority of them, are on a benzodiazepine unless they prefer not to be. Witnessing an arrest, I think probably that's the most traumatic event one can have in a CCU. Even those people, and a fair number of them, I would say a third of those that we interviewed, admitted fear. Even those who didn't admit fear generally ended up by asking for a narcotic or sedation or a sleeping pill or something after the experience. So I would say that it is a traumatic event for the patient, no matter what they say. For the most part, however, they are, I won't say reassured, but they're impressed by it. They're impressed by the speed of the team, by the time they take in trying to revitalize somebody. And usually they will respond to the reassurance given by the nurse. The nurse, almost invariably the doctor, will separate their condition from the condition of the person who had the arrest by indicating that individual's cardiac status was much worse. There has been a significant failure of those witnesses, of those who watch, to identify with the patient. It's a very protective mechanism. Surviving arrest, I'm sure you know better than I do that the majority of people who survive arrest do not experience traumatic neuroses. In the beginning, when arrests began and the psychiatric effects of them began to reach the literature, one of the first reports would have us believe that it was very much like a traumatic neurosis. These people who'd been defibrillated, revitalized, had dreams of being burned up, had startle responses, had depressive reactions. Our own experience was so contrary to this that we checked into the individuals at Columbia, it was who turned out the original report, and we found that their population was a good deal different from ours. Our individuals, most of them did not remember the arrest and the revitalization. They had no memory for it at all. We were particularly interested in that because one of the people that I've done the most work with is a Jesuit priest, Ned Casson, who's a psychiatrist as well. And arresting is about as close as you can get to the other side and come back. And he was interested to find out what they saw. They didn't see anything. I mean, we had no life after life experiences. Nobody went up there and came back down again. The only person that we had who had any kind of an experience was an individual, a psychologist, who had his MI in front of the Boston Public Library, was brought into the EW, and immediately asked to check out because his wife was a nurse, and he was with his mistress in front of the public library, and she was there when he came in. They gave him the slip to sign to get out because he insisted on leaving, and as he left, he arrested. And he had the following dream. He was trussed up like a beef, bound up by cord on a counter, a checkout counter at a supermarket, a Star Market. And he's going down this conveyor belt to a checkout woman who was checking out things and tossing away vegetables. And suddenly he woke up and said, "Christ, what a bunch of clerks in this meat market," looking around the doctors. And then he related the dream. But that's the only experience that we had dreaming or with arrest experiences. Surviving arrest, the machinery of intensive care. Well, one thing I would like to mention, and I think I better hit the first slide. I'm way behind on my slide. Anxiety that's present at all is there usually for the first day, and you'll notice denial that comes up. Denial is a very interesting defense, and one that we've been particularly impressed with. What it means is the conscious, here let me put the slide on it. The conscious or unconscious repudiation of all or part of the total available medium of event to allay fear, anxiety, or other unpleasant affects. Basically what it means is a denier is somebody who's able to suppress or reduce fear. It's like, I use the example of getting on an airplane. You get on an airplane and you don't think of pilot drunkenness. I mean, you don't really think of the amount of air traffic over O'Hare. You don't think of gravity. I mean, you don't think of the weight underneath the airplane. What you do is you think of the power of the plane. You suppress it. You're wise. You push down all thoughts about hijacking and everything else. And you sit back and enjoy yourself. In a funny way, the CCU might be the same kind of thing. You go in there, and if you think it's the best possible place to be under the circumstances, you've got an MI, and you couldn't be in a better place than where you are. You've got the best doctor in the world. Let them do the worrying. Now, if you can achieve that equanimity, you're in much better shape than if you worry. Basically, deniers are people who don't worry very much, and what we found in the CCU is that those who can attain this have a better time, less mortality. lower mortality rate and actually lower morbidities than those who are worriers. And the tendency is that in the post-hospital phase, in the convalescent phase, the same thing holds true. Individuals who are basically non-worriers do better in terms of their life, in terms of return to work and social life, than those who worry. It's kind of a simplistic way of looking at it, and it's a far more complicated matter when you come down to objectively measuring denial, and I'll be glad to answer questions about that after the talk if anybody's interested. But denial is something that we were interested in and we found to be very helpful. The post-hospital phase, or the convalescent phase, has interested us a great deal. And what we spend most of our time doing in the post-hospital phase is in describing a depression that Herman Hellerstein described some time ago himself. He said that it is a universal response, depression, after MI. And we certainly categorize that as being universal. And we have compared it to major depressive episodes or major affective disorders, or what one might call just a major depression, as they're defined by the American Psychiatric Association. Now, that's the definition of a major depression. It differs a good deal from a post-MI depression in the following. In the CCU, as I mentioned, depression, or you saw from the slide, depression doesn't usually begin until about the third or fourth day. And then it starts more as a concern about what's going to happen to me when I get out, and a worry that I won't be able to bring in the money for paying the groceries, doing what I was doing before. I won't be a good husband. It doesn't really become a depression in that sense until the person goes home. Now, when they go home, unless they have an activity program in the hospital, when they go home, the first thing they do usually is to walk around their property. It's like some kind of peculiar territorial response. They walk, and the walking produces fatigue, a sense of lassitude. And many of them misinterpret this to see it as a signal that their heart is more damaged than they were told. And this is usually the beginning of a more major depressive reaction, in which the secondary symptoms of depression come. Appetite change, either anorexia or hyperphagia, sleep change, often early morning awakening, loss of interest in sports and hobbies, decreased libido, hopelessness, irritability, poor concentration, indecisiveness, and sometimes recurrent thoughts of death or suicide, but those are much more rare. Usually the post-MI depressions are more in the order of what has been referred to as a masked depression. That is, the person doesn't complain of being depressed, but he will complain about being weak, or he'll complain about palpitations. He'll complain about some physical happening, headache or some other pain. And along with that will come the fatigue, the anxiety, the poor concentration, memory disturbances, and so forth. It can be treated as a regular depression, however. It's a reactive depression. It's reactive to the coronary condition. And it should be, if it follows true to form, limited to about 2 to 3 months. Again, this is a finding that Herman and Nanette Wenger pointed out some time back when they wrote a paper describing that about 85% of these people overcome their depression and get back to work in about 3 months. 15% don't. Our findings are exactly in the same category. 15% usually develop cardiac symptoms, and many of them become cardiac cripples. How could you predict it? I mean, are there things that you could look for? Well, there's some correlation between the severity of the cardiac impairment and depression, although not nearly as much as you would think. I think more important is the presence or absence of social supports. If the family is good and supportive, if the person has a good social network, he's much more apt not to be so depressed. If he has a history of depression, a susceptibility of depressive illness, that can compound things and make a depression much worse. And if the person happens to be a manic depressive, it not infrequently triggers off a depressive episode. Then again is the adaptive capacity. If the person is a good denier, if he responds to stress well, then I think there's less chance of the depression is becoming serious. The signs, that one of the first signs of the depression's clearing up be a return to active social life or a return to sexual functioning, a return to interest in intercourse, signals the beginning of a return. The sources of it, why it comes, I don't think it's very hard to explain why the depression comes. An MI is it gives the individual the first glimpse of mortality. I think that's a very important thing. But the other thing is that most people fall into the sick role very easily. Sick role, they've learned, they've heard that the individual with an MI changes his lifestyle, has to adapt to certain things that he didn't have to adapt to before, has to slow down, has to do things that somebody who is more middle-aged would do. I think of the sick role, and I think of an experience I had when I was in Chillicothe, Ohio, doing my armed service time. One of the patients went over the wall. There was a big reformatory down there that is gone now, but this fellow escaped. And he was going across the field, a guard shot him. And I had to go out and get him. And I dreaded the prospect. I went out, and he was lying on his back, and I couldn't see any blood. And I said, "How are you?" And he said, "Okay." And I said, "Where were you hit?" And he said, "In the shoulder." So I looked at his shoulder, and the bullet had singed his shirt and just barely touched the skin, but no blood. And I said, "And where else?" He said, "That's it." And I said, "Well, just how come you fell down?" He said, "When you're shot, you're supposed to fall down." He had assumed the sick role. And I think that's what a lot of people do with an MI. They assume they are going to be crippled. And that's one reason I think that exercise programs have made a tremendous difference in the control and in the care of these people. If you can tell somebody who has been in a CCU and gotten out that you know people who've been in the same bed he's been, who've run the marathon, it surprises them. And also, if you can point out activity programs to them that are going on right in the hospital, induce them to try it out, to join a heart club or a cardiac club, I think the chances of their being taken up by that kind of lifestyle are about maybe 1 in 5. I don't know how, I have no idea how you induce somebody to exercise who doesn't want to. We used to try, for those who wouldn't do it, we used to try relaxation techniques and auto-hypnosis. But we found that the same kind of people who enjoy jogging will take the relaxation and hypnosis. Those who reject jogging are very apt, or swimming or walking, are very apt to reject hypnosis. So about those individuals, I can't really say what one does to motivate them, but we certainly have some success with our cardiac groups. They're going on now, and I think if anything, they've grown in size. We've tried to implement some programs that Meyer Friedman has started to change type A behavior. I am not a big type A man myself. I don't really follow their reasoning on that, although it's something to do, so we do it. I think that the final card on that hasn't come out. I think it'll require a number of replications before anyone can fully believe what they're putting out. Medications, we don't use medication very much other than anti-anxiety. Anxiolytics are used during convalescence if the person needs them to re-socialize. Antidepressants can be safely used whether they're, oops, I better put this on, whether they're tricyclic antidepressants or monoamine oxidase inhibitors. If the depression lasts longer than 3 months, if it contains the vegetative signs that I've spoken of before, and particularly if the person has a depressive diathesis, we then use antidepressants. There are a core of these individuals, about 5%, I would say, who become cardiac cripples, and about them, I am not sure what one does. I personally had very little success in treating them. I don't know that there's any program that one can use to do so. I think they're probably about, well, their lot is somewhat improved in the last 15 years because with a certain number of them, the antidepressants and psychostimulants have helped. And by psychostimulants, I mean Ritalin and amphetamines. They've been of some value in activating people. But this hardcore of 5% or so, I am at a loss to do anything about. I don't really have almost stopped trying. We have a great deal of spend a fair amount of time educating families. So I mentioned cardiac groups. The patients taken into the cardiac group, they're usually run by a psychiatrist who is interested in cardiology, and most of the time, they don't do group therapy, they do group education. The spouses have insisted upon having their own groups, and we do that too. We spend a fair amount of time educating people sexually, because one of the major concerns of individuals leaving the hospital after an MI is the John Garfield syndrome, or the Rockefeller syndrome, whatever it is that you want to call it right now. That is death at orgasm. Of course, Herman and Ernie Friedman have done a great deal to combat that by their very creative studies about monitoring the sexual response of lawyers in Shaker Heights. I mean, the fact that they had the equivalent in Metz of only walking up 2 flights of stairs, I think is more a comment about sexuality in Shaker Heights than it is but it has been a guidepost for all of us in educating these people. I do always tell them about the Ueno study, which probably most of you know, the Japanese pathologist who had something close to 5,000 sudden deaths in Tokyo, and of which 34 of them occurred in flagrante delicto during intercourse. Now, of those 34, 30 were with people other than their wives. And if that wasn't enough, there was an age difference of minimum of 14 years. In one case, a difference of close to 60 years. And also a blood level, an alcohol blood level that was in the red zone, or in the intoxicated zone. So we tell them that. We tell them that they should stay in their own nest. Which sorely tempts me to show the next slide, which I will do for a moment, and then I will corner, have a care, think before that new affair. Dr. Zoman studied swingers, and her facts are really zingers. Sex, domestic, also straight, hardly makes you palpitate. Heartbeats stay at normal rate when one beds with legal mate. And the danger that it bears looms like, well, 2 sets of stairs. But roosting in another's nest flirts with cardiac arrest. End result of evening sport is very often rigor mortis. So seduction's needs are 3: soft lights, music, EKG. Thank you.
If there are any questions, it's hard to believe that the audience fell asleep. Howard?
To come back to follow. Around the community, certainly I think this is representative of most of our patients who discharge from antidepressants. One of my patients told me the community nickname for Inderall. A lot of men call it Indorol. And that's no surprise, because those of us who do carefully talk to our patients, having been taught by Herman, are aware of the fact that many of the depressive reactions are in fact beta blocker blues. My question is, how does one separate beta blocker blues from the blues of a myocardial infarction? And how successful are you in treating the depression due to beta blockers with antidepressants? Most of us don't do that. We take people off beta blockers. But have you had any experience with beta blocker-induced depression responding to the antidepressant?
I'm not sure whether the Boston population is different. That has not been much of a problem. What we do is switch from one beta blocker to another. Atenolol, for example, is one that we use now a little more than Inderol. I don't know, I've seen it, but if you compare that to the kind of depressive response one gets to antidepressants or antihypertensives, there's very little comparison. I mean, I think that the beta blocker depression lets up as soon as you stop the beta blockers. And that would be one of the ways that one could determine the etiology. The post-MI depression usually has as its presenting symptom weakness, as I say, lassitude. The low state of mind, and the physical inability to have intercourse, which is more characteristic, I understand, of Inderol, is not, the lassitude is not as important a feature in the Inderol depression as a low state of mind, as the feeling of dysphoria. those are the most practical differential test I can think of is simply stopping the beta blocker to see if it clears up, and it will clear up within days. Now, what to do if they need a beta blocker, I think you take your choice. And you can tell the gentleman to take his choice. Sometimes, there are weekend holidays, off the drug for a trip to the motel. But it's a tricky problem.
I think you guys stop. We will have a coffee break now, and let's reconvene promptly in 10 minutes. You just follow.
I have a couple of my own stories I'd like to share with you before I proceed on with the text. Some of these are now famous, particularly the second one. It was interesting to note that when I came to Case Western Reserve many years ago as a physiologist, PhD, within the first week of my being here, I was essentially intimidated by Dr. Hellerstein, and he said to me, "Barry, do you know how to read the electrocardiograms?" And I said, "Of course, I think I'm fairly good." And he said, held up an electrocardiogram, said, "What is this?" And I gave him an answer, and he said, "Wrong." And he held up another electrocardiogram and held it about here and said, "What is this electrocardiogram?" And I hesitated because I was trying to figure it out and found the electrocardiogram placed on my forehead very quickly, as if I'd be able to understand it a little quicker. And at that time he said to me, "You don't know how to read cardiograms. You're going to come upstairs and spend 6 weeks with the residents and actually learn how to read cardiograms." And I did. I'll never forget the first day sitting at a round table with a number of physicians. He was going around the room and he said to me, "Barry, what is this cardiogram?" And I gave him an answer, and I'll never forget, he was silent for a second, and then he said, "You smoke." And I said, "No, why, Dr. Hellerstein?" He said, "Well, people who smoke don't see very well." And that was my orientation here at Case Reserve many years ago in terms of reading electrocardiograms. One other quick story, and that is it's now known as the famous airport story. My first experience in traveling with Dr. Hellerstein, many years ago, I was here just a few short months, and we were on a panel together that he had arranged, and we were leaving for the airport, and I noticed that the plane was due to leave at 2 o'clock, and at 1 o'clock I approached him in his office and said, "Dr. Hellerstein, I think we probably better leave now." And he said, "Barry, plenty of time." So I just walked back to the office, and I didn't say anything. Then I came back about 20 minutes later and said, "Dr. Hellerstein, do you think we should leave? It's about 40 minutes before the plane leaves." And he emphasized that time is very valuable. We didn't want to wait in the airport, and so on and so forth. And he said to me, "It's 28 minutes to the airport. We have plenty of time. We've got 40 minutes to go." And finally, we left 35 minutes before the plane was due to take off. And he was driving, and I was sitting next to him, and we're driving along, and certainly on schedule. And then all of a sudden I looked ahead, and there was a sign, "Road work ahead, single lane, 10 miles per hour." And I glanced over at Dr. Hellerstein, and I sensed that he felt, and we both knew that we were going to be late. We probably weren't going to make this plane. He drove as fast as he could. He was weaving in and out, trying to get to the airport as soon as we could, and we finally arrived right at the time the plane was due to depart. We both literally jumped out of the car. We both started running with our bags. And after about 10 or 15 feet, he said to me, "Barry, stop. Take my bag. See if you can catch this plane." I now carry 2 bags, my bag and Dr. Hellerstein's bag, which probably had 2,000 slides, several textbooks, and so on and so forth. And to be frank with you, I'm running my ass off to try to catch this plane. Dr. Hellerstein was proceeding down the corridor very slowly, methodically, and I was running and running and running, and finally, believe it or not, got to the gate, and they were just closing the gate, and I was able to hold them up. And he continued to walk down the aisle. I could see him coming far down the distance, and I was waving that I stopped the plane. We're okay. sat down together. I'll never forget this. And at this time, I was sweating profusely. I unbuttoned my tie and leaned my head back just gently and closed my eyes. And he was sitting right next to me. And before I knew it, there was a hand palpating my pulse. And I opened my eyes. I mean, you can't make up something like this. I opened my eyes, and he was taking my pulse. And he was palpating it, and he goes, 150. Then he proceeded to find his own wrist, took his own pulse, and he said 72. He then looked at me in a very, very interesting way and said, "What a pity. Franklin, you're in no shape whatsoever." My topic this afternoon is chronic adaptations to exercise training, with specific reference to the patient with coronary artery disease. The format I'd like to follow is shown on the first slide, where we'll talk about some changes that occur in functional capacity, some factors that affect exercise trainability, the role that exercise plays in reducing angina, the effect of exercise training on selected coronary risk factors, most notably serum lipids, and finally, psychosocial adaptations. Certainly when we talk about functional capacity, it's important in this day and age to define functional capacity in more than aerobic capacity terms. In other words, today physiologists typically define functional capacity as aerobic capacity, or VO2 max, as well as another term called the anaerobic threshold or ventilatory threshold. Both have relevance when we talk about a patient's capacity to function. Certainly we recognize that oxygen uptake is a function of two variables: cardiac output, determined by heart rate and stroke volume, times arterial venous oxygen difference. We also recognize that certainly in the laboratory we have the capacity to both measure oxygen uptake and estimate that variable, although we're seeing more and more evidence certainly that when it's possible we should be measuring oxygen uptake instead of estimating it, due to gross errors in estimation of oxygen uptake from standard tables or nomograms. We also have come to recognize that from a functional standpoint, exercise training is very valuable in patients with coronary artery disease, simply because the VO2 max in the patient with coronary artery disease is typically 50 to 60% of the age-sex-matched counterpart. In other words, the individual who does not have coronary artery disease. And we now recognize two major reasons why aerobic capacity, or VO2 max, is reduced in the patient with coronary disease. The first factor is diminished cardiac output. Clearly, as we look at that equation, cardiac output times AVO2 difference, the primary limitation in the patient with coronary artery disease is a central one: lower stroke volume, lower cardiac output, and hence lower VO2. That may be due to two factors. One, diminished contractile force of the left ventricle, and oftentimes we see restriction in the rise of heart rate in patients with coronary disease. Secondly, we've come to recognize that prolonged bed rest and inactivity also contributes markedly to the deficits that we see in functional capacity. I think some very, very interesting recent findings, and certainly we're all familiar with the fact that prolonged bed rest results in a very significant decrement in functional capacity, and up until recently, we really attributed that decrement to simply the absence of regular daily physical activity. Some very exciting, relatively recent research, in fact, suggests that that decrement in aerobic capacity is probably more likely due in part, to lack of regular cardiovascular orthostatic stress. Indeed, when the astronauts have come back, we have recognized marked deficiencies in functional capacity simply due to the lack of gravity. The implications then for the patient with coronary artery disease are that intermittent sitting or standing during the hospital confinement period will go a long way in
of reducing the deficits that we see in functional capacity that occur with prolonged bed rest or inactivity. So perhaps equally as important as the inpatient cardiac rehabilitation is the fact that if we can simply get patients intermittently during the day, sitting up or standing, subjecting them to that gravitational or orthostatic stress, we can go a long way in terms of reducing the deficits that normally occur with inactivity. What about the role of exercise training on functional capacity? Certainly, as we look at typical guidelines that are recommended for exercise training, we generally see these particular guidelines, which to a large extent were defined by Dr. Hellerstein and others many years ago, in terms of defining the optimal intensity for exercise training. That optimal intensity for most patients corresponds to 70 to 85% of maximal heart rate, equivalent to approximately 60 to 80% of the aerobic capacity. As shown here, once again from a slide, Dr. Hellerstein's text, we see that as we relate the optimal intensity of training related to here the anaerobic threshold and the Borg scale for perceived exertion, it's apparent that when we talk about outpatient physical training programs, the rating of perceived exertion should generally be compatible with ratings of 13 to 15, corresponding to somewhat hard to hard. It's important to emphasize that patients need not exceed this level in order to get a sufficient cardiovascular conditioning effect. What is the effect of exercise training then on oxygen uptake? Here we've clearly come to recognize that a physical training program results in a marked improvement in maximal oxygen uptake, typically between 15 and 25% in most studies, this being a rare exception, a 50% increase. The point we should make here is that it's important from a functional standpoint in that a given task requires a certain amount of work expressed on an ml per kg per minute basis, and whether that task is done before or after the training program, it still requires the same relative oxygen consumption. As a result, after a conditioning program, with an improvement in aerobic capacity, the patient finds that he or she, throughout the day, is now working at a lower percentage of their functional capacity, hence with greater reserve. We now recognize, too, that that improvement in aerobic capacity is due to two factors. Perhaps increases in central factors, an increase in stroke volume, increase in maximal cardiac output, but perhaps more importantly, we've come to recognize that peripheral factors, that is an increase in the size and number of skeletal muscle mitochondria, an increase in oxidative enzymes, an increase in muscle capillary density, all contribute to an increased oxidative capacity of skeletal muscle, hence enhancing arterial venous oxygen difference, the other portion of that equation, and hence enhancing the patient's capacity for oxygen uptake. A second definition or variable that you should be familiar with is the anaerobic threshold. The anaerobic threshold really reveals the peak rate of oxygen uptake expressed on an absolute or relative basis that can be sustained by an individual without developing a significant increase in blood lactic acid and muscle fatigue. We now have some very elegant data, both comparing invasive and non-invasive variables, that this abrupt increase in blood lactate, which you see here during a bout of exercise, is paralleled by abrupt increases in non-invasive variables, that is, abrupt increases in CO2 production and minute ventilation. Hence, physiologists now oftentimes use this abrupt increase in minute ventilation to signify the anaerobic or ventilatory threshold. And indeed, if we can define this particular point, the point just below the point of abrupt increase in minute ventilation, we then define the highest level of exertion that can be sustained without developing significant muscle fatigue or lactic acid buildup. The exciting news is that in both cardiac patients and normal individuals, we find that physical training not only improves the VO2 max expressed on an absolute and relative basis, but that physical training also improves the anaerobic threshold, once again, on a liter per minute or percent VO2 max basis. Until fairly recently, these data were limited to normal individuals, and now we have several studies which have shown that exercise training, rhythmic, dynamic, aerobic types of training, improves the anaerobic or ventilatory threshold in cardiac patients, including those with impaired left ventricular function. Exercise trainability is a second category that we want to cover. And in essence here, we're talking about those variables that may potentially affect the exercise training response. As we look at exercise trainability, there are three variables that the literature suggests may in fact influence an individual's ability to profit from an exercise training program. They include 1, clinical status, 2, medications, particularly beta blockade, and 3, left ventricular dysfunction. These are data from Hartung and coworkers in which they compared 3 subsets of cardiac patients, myocardial infarction patients, patients with documented coronary disease, and patients who had undergone coronary revascularization surgery. Here we see the VO2 max, pre and post conditioning program, and the point that these investigators made is that VO2 max improved in all groups and improved on a similar relative or percentage basis, suggesting that one group does not have a particular advantage over another in terms of their ability to profit from an exercise training program. Question of beta blockade has also been brought up. Certainly we are familiar with the attenuating effects of beta blockade on heart rate, and indeed many investigators have speculated that beta blockade may blunt or attenuate the conditioning response. As we look at these data from Pratt and coworkers, which appeared in Circulation, we had 3 groups: Group 1, no beta blockade; Group 2, low-dose beta blockade; and Group 3, high-dose beta blockade. And here we see the improvement in exercise duration and estimated aerobic capacity pre and post conditioning. These data indeed suggest, in fact clearly indicate, that beta blockade does not attenuate the training response. We now have many studies which have shown that cardiac patients on beta blockade can and do improve functional capacity. Although many individuals attribute an increase in heart rate to the conditioning effect, I think it's clear that the major factor that is responsible for improvement in cardiorespiratory function is an improvement in body oxygen uptake. In fact, we now have data that indicate even among patients with fixed heart rate pacemakers, we can see improvement in aerobic capacity as a result of a conditioning program. So although heart rate may be a correlate of oxygen uptake, the real key in terms of improving cardiorespiratory fitness is to improve or increase total body oxygen consumption. The third area certainly is exercise training in patients with impaired left ventricular function. And certainly for many years, these patients were excluded from exercise training programs. Over the last decade, we have several studies which indicate, number one, that left ventricular ejection fraction actually correlates very poorly with functional capacity. And indeed, individuals can have poor left ventricular function and have a normal or near normal functional capacity. Secondly, we've also come to recognize that exercise training can be conducted safely and effectively in patients with low left ventricular ejection fractions. If we look here, for example, at the data of Kahn and coworkers, as published in the American Journal of Cardiology, patients all with left ventricular ejection fractions less than 40%, and here, as a result of a conditioning program, we see significant improvement in measured METs and oxygen pulse. Angina pectoris, another area certainly that exercise training beneficially affects. The reasons or possible mechanisms for improvement of angina following an exercise training are twofold. One, either a reduction in myocardial oxygen demand; 2, an increase in myocardial oxygen supply; or 3, both factors. Certainly we recognize the classic studies of a number of investigators which have shown that at a given rate pressure product, the magnitude of ST segment depression or the provocation of angina is relatively consistent. For For example, in this angina patient, under 4 progressive workloads, 3, 5, 7, and 900 kilopound meters per minute, we see the increase in the heart rate, blood pressure product, and estimated myocardial oxygen demand under the 4 circumstances. What the investigators have done here is simply denoted the onset of angina with arrows in these 3 instances, and it's apparent that angina occurs at roughly the same rate pressure product in all 3 circumstances. That then would suggest that for selected patients, there is an ischemic threshold whereby myocardial oxygen demand exceeds myocardial oxygen supply. And indeed, for many years, we pointed out that simply myocardial oxygen consumption, as estimated by the heart rate systolic blood pressure product, was reduced at any given workload for total body oxygen uptake, thus favoring a hypothesis that exercise training primarily affects or primarily reduces myocardial oxygen demand. These data were further confirmed by some early studies in 1970 by Detry and Bruce, in which they compared the magnitude of ST segment depression at a given heart rate blood pressure product. The hypothesis being that if indeed myocardial oxygenation is improved, they should see, after an exercise training program, a reduction in the magnitude of ST segment depression at a given rate pressure product. In essence, as we look at their data, they saw no such finding following a 3-session per week, 12-week moderate intensity physical conditioning program, and concluded then that the relief of angina was primarily due to a reduction in myocardial oxygen demand as opposed to an increase in myocardial oxygen supply. For many years, then, we cited data such as these suggesting that demand was far more important than supply in terms of exercise training benefits. These data held for many years until some recent studies by Asani and co-workers in which they studied the effects of high-intensity aerobic exercise training for a period of 12 months at 3 to 4 sessions per week at an intensity of 89 to 90% of aerobic capacity. And lo and behold, they got far different findings than this earlier report. They published these findings, in fact, in Circulation, and really stunned many cardiologists and the medical community in general by the suggestion that this type of training may actually improve myocardial oxygenation. Basically, what we see here was a significant difference in ST segment depression pre versus post. This was pre-training, this was post-training at a given magnitude of ST segment depression. I highlight these data because I think they illustrate one very, very important point, and that is, to a large extent, we have gathered information on exercise training programs largely from short-term exercise training studies. Certainly when I counsel graduate students, I know of no graduate student who wants to do a 1-year or 2-year or 3-year exercise training study. Everyone wants to do a 6-week or 10-week or 12-week exercise training study, and as we look at the literature, the vast amount of information we have is based on short-term exercise training studies. What these data suggest is that if the exercise intensity is high enough, if the duration is long enough, we may indeed evoke central changes. That is, changes at the level of the heart per se. Let's then summarize everything that we've talked about so far. We certainly recognize that VO2 max and physical work capacity increase, and secondly, at a given submaximal workload, heart rate, blood pressure, and myocardial aerobic requirements are decreased. I think it's important to note, however, that these latter changes are to a large extent specific to the skeletal muscle groups that have been utilized in the exercise training program. Dr. Hellerstein, you should recognize this gentleman, a former individual involved in our National Exercise and Heart Disease Program. This was an arm ergometer essentially devised by Dr. Hellerstein in his laboratory here. And it's these types of studies that first got me interested in the whole concept of upper extremity testing and training. Here we'll share with you, if we can focus that, a very, very classic study which has been replicated on numerous occasions with the findings very compatible from one study to another. The study was done by Clausen and coworkers, in which they initially tested a group of young men, and then they tested their arm performance, and then they tested their leg performance, and divide the group into two. One group subsequently trained their arms for a short period of time, the other group trained their legs, and at the end of the exercise training program, both groups were brought back and retested for improvements in both arm and leg performance. The results are shown in this slide. As we look here, the arm training group, these are heart rates pre, and post. The arm training group, as you can see, showed much lower heart rates at a given submaximal workload during arm work, while the heart rates during leg exercise were essentially unchanged. Similarly, the group that leg trained showed much lower heart rates during the performance of a standard submaximal workload during leg work, yet the heart rates during arm work were virtually unchanged. What these data highlight is what is known as the principle of training specificity. That being that cardiorespiratory adaptations to exercise training programs are largely specific to the muscle groups that have been trained during the program. An individual then whose occupation or leisure time activity requires upper body efforts should be concerned with training the upper body as well. I will never forget a quote that Dr. Hellerstein made at a conference on the marathon, and he stated that there are very few occupations that require sustained walking or jogging. Examples he provided are postmen, protective service personnel, police officers, and their fugitives. 4 major occupations where you need to run like heck for a sustained period of time. And as we began designing cardiac exercise training programs, we began to recognize more and more the principle of training specificity and its importance in the design of adult fitness and cardiac rehabilitation programs. Indeed, Michael Pollack's national survey of cardiac rehabilitation programs across the country clearly showed that more and more emphasis is being placed on upper body training. That upper body training may include arm ergometry, rowing, and lifting light weights. Furthermore, there are now several reports attesting to the safety of upper body training, that is, showing no greater incidence of cardiac arrhythmias, angina, or symptoms at similar heart rates as that performed during leg exercise. So there appears to be nothing deleterious about performing upper body exercise training activities. In our own programs, we've utilized a wide variety of upper and lower extremity exercise modalities, to a large extent modified or adapted from Dr. Hellerstein's laboratory and the National Exercise and Heart Disease Project. We've used treadmill walking, we've used Schwinn-Erdine cycle ergometry in this mode, as well as modifying it for upper body training. We've utilized a variety of arm ergometers. We've utilized a rowing machine. We've even utilized the Nordic cross-country ski device for our patients with coronary artery disease with great success, combining both upper and lower extremity exercise training. For those of you who saw Rocky IV, we have recently implemented the VersaClimber, a ladder simulated type device which exercises the upper and lower extremities, and once again find that this device is well tolerated by our patients with coronary artery disease. To share with you some of our own research studies, several years ago we were interested in comparing the trainability of the arms versus legs, and we said, geez, if we have an individual who has 30 minutes of exercise training to devote 3 days per week, and we have them train the upper extremities for half that time, and we have them train the lower extremities for the remainder of the training period, that is 15 minutes each. The question we had was, do the arms respond in the same qualitative and quantitative manner as do the legs? Do they show the same magnitude of improvement? We tested individuals on both exercise modalities, arm training and leg training. Here we expressed the VO2 in METs for arm work pre and post and leg work pre and post. It was interesting to note that the percentage improvement in arm aerobic capacity was 13%, for legs 11.5. As we compared power outputs pre and post, once again we saw a 24% improvement here, a 23% improvement here, keeping in mind we allocated equal time to the arms and legs. As we plotted the rate pressure product as a function of increasing workload for arms versus legs, once again, for both arms and legs, we saw a shift in the regression downward and to the right, suggesting that after training, we saw a lower rate pressure product for both exercise modalities, which quantitatively were very similar. Let's move on to another topic, and that is fitness for what? Conditioning is specific. In addition to rhythmic dynamic upper body training, we also feel that there is a need to strengthen or use strengthening types of activities in our patients with coronary artery disease. Indeed, the rationale for muscular strength and endurance training is very clear. Many leisure and occupational tasks require lifting, movements, holding a weight. And indeed, these even types of recommendations stem from Dr. Hellerstein's initial studies in the 1950s on the work classification clinic, where he clearly defined what are the physical requirements of occupational work. I think it's important to note, particularly to cardiologists, that in recent years, several research studies have in fact highlighted the fact that isometric exercise or static types of exertion is less hazardous than we once thought. There are four major findings that we want to call your attention to here. First major finding, in which several studies have shown, is that isometric exercise, regardless of the percentage of maximal voluntary contraction, generally fails to produce angina, ST segment depression, significant ventricular arrhythmias among selected cardiac patients. Second major finding is that the heart rate systolic blood pressure product is actually lower during maximal isometric than during maximal dynamic or isotonic exercise. The third major finding is largely attributed to Dr. Haskell and his group at Stanford, in which they showed that elevated diastolic pressure may actually contribute to a lower incidence of ischemic responses during isometric or combined isometric dynamic effort. And lastly, and perhaps most significant, by superimposing static on dynamic effort, the heart rate systolic blood pressure product at ischemia is actually increased. So these findings, taken as a whole, based on a number of studies, have really changed our attitudes regarding the role of static exercise or the static component of upper body types of activities. Indeed, if we look at Ferguson's study and his result, their conclusion was isometric and dynamic arm exercises that involve a static component have been shown to be safe procedures. And furthermore, these types of exercises in medically supervised programs should improve the ability of many individuals to respond to reasonable occupational and leisure time types of activities. In our own laboratory, we have examined Nautilus exercise training and examined the heart rate, blood pressure, ECG, and symptom responses to Nautilus exercise in comparison to peak or symptom-limited graded exercise testing. Nautilus workloads were estimated at 40% of maximal voluntary contraction, and the loads were considerably greater than those used in previous studies. If we look at the variety of Nautilus stations here, even at the lowest workloads, the mean weight here was 30 pounds and all the way up to 105 pounds. Here we've simply illustrated for you four variables: systolic blood pressure, mean systolic pressure, double product, the heart rate, and the diastolic blood pressure throughout the Nautilus circuit training. Keep in mind, these are peak responses. I think if we were to summarize this entire slide, we'd use the word unremarkable. Moreover, as we compared peak heart rate during Nautilus exercise training with that derived from maximal graded exercise testing, it's very, very interesting to note that all throughout the exercise format, heart rate typically ranged from 50 to 60% of the peak heart rate attained on graded exercise testing. Once again, as we compare the double product at maximal graded exercise, at angina, at the ischemic threshold during graded exercise testing, and during Nautilus exercise, once again we were surprised to note how relatively low the double product goes during Nautilus types of training. No patients experienced symptoms. There was no evidence of ventricular ectopy, and once again, heart rate and blood pressure responses were well within normal limits. I think to conclude this particular section, we would quote Dr. Gunnar Blomqvist in an article he wrote for Dr. Wenger's text, in which the conclusion being, in a general sense, the data support that therapeutic exercise programs should not be limited to dynamic leg exercise, but should include upper body activities, something that Dr. Hellerstein has stressed for some 10 or 15 years. Moreover, exercise specifically designed to improve muscle strength may be beneficial, and the exclusion of all activities requiring predominantly static efforts is not warranted. So we're moving from the walking, jogging concept to an exercise training program that is far more comprehensive in nature, to an exercise training program that is tailored to the individual to enhance muscular strength or endurance, particularly if that individual uses those fitness components in their work or recreational types of activities. I want to touch briefly on coronary risk factors, and certainly we are familiar with the effects of exercise training on body weight and fat stores, but just to give you a brief update on serum lipids. This was a paper done several years ago in which they surveyed 66 published studies. They have subsequently added another 30 and published a recent article in the Journal of American Medical Association, but their conclusion was the following. Exercise training may be beneficial, particularly in people with high cholesterol levels to begin with. They found the more time anyone spent in physical activity, the greater the improvement. Furthermore, high-intensity activity was not particularly helpful in bettering the levels of serum cholesterol. Perhaps more importantly, they noted that these changes were indeed magnified when body weight and fat losses accompanied the exercise training program. Certainly the hot area, one in which Dr. Haskell and his co-workers have been actively involved in for years, is certainly the effect of exercise training on the beneficial or anti-atherogenic HDL cholesterol level. We recently surveyed 9 published studies on exercise training and cardiac patients, and of those 9, 8 of the 9 showed increases in HDL with regular exercise training with a range of 5 to 23% with an average of 13%. I think it's also important to note, once again from the Stanford group, that there may indeed be a threshold level for exercise training and HDL cholesterol levels. And indeed, in our experience, many times we have not seen improvements in HDL cholesterol as a result of an exercise training program. Yet, oftentimes when we look back and we see what our patients were doing, oftentimes they were less than that 8 to 10 miles per week. In many instances, I've told our patients that they may be better talkers than walkers. And as a result, in terms of total kilocalories expended, they are perhaps not getting up to that critical level of 8 to 10, what has been suggested is 8 to 10 miles per week. Finally, some myths and misconceptions. And certainly while we are supportive of exercise, I think it's important to look at what the data tells us relative to all the benefits that we've been telling patients for so many years. Certainly, as we look at 3, what we consider to be major myths and misconceptions, exercise training improves collateral circulation, exercise training enhances coronary vessel size, and the marathoner and immunity hypothesis. Clearly, we do not have good evidence today that exercise training in itself improves coronary collateral circulation. The primary stimulus for collateral circulation appears to be severe stenosis with or without exercise training. At least angiographic studies, more recent angiographic studies, do not support the benefits of exercise training in enhancing collateral circulation. Secondly, coronary vessel size. And indeed, the autopsy of the famous marathon runner Clarence DeMar is often cited to individuals with the suggestion that vigorous exercise training may indeed improve coronary vessel size. I think it's important to note, however, as we look at the history of Clarence DeMar, some have estimated that he ran an average of 8 to 12 miles per day over a 40 to 50 year period. I think it's difficult to extrapolate those kinds of physical performance levels to our individuals who enter the YMCA or Jewish Community Center and walk or jog 2 miles or 2.5 miles 3 days per week. It's also not clear whether, in fact, Clarence DeMar was not born with unusually large coronary arteries. So I think it's a difficult extrapolation to say that physical activity definitely will enhance coronary vessel size. And thirdly, certainly the marathoner and immunity hypothesis, which was really started in 1972 by Dr. Thomas Bassler in a letter to Lancet proclaiming that marathon runners, and particularly those who believed in the marathoner lifestyle, were virtually immune to coronary artery disease. Certainly, while we believe in the benefits of exercise, perhaps one of the first people to speak out against this hypothesis was Dr. Herman Hellerstein, once again. He said, while we believe in the benefits of exercise, certainly the data is not conclusive that exercise training, even at extreme levels, will provide immunity to coronary disease. And once again, he's been proven to be right, not only with this study, but the Jim Fix and a number of other case reports. So I think it's clear that, in the words of Dr. Hellerstein, while exercise training certainly may reduce the incidence of coronary artery disease, it may be an important preventive measure, it does not provide immunity to coronary artery disease. And certainly if we recognize anything, that is structure and function are not synonymous. That is simply because an individual can perform well on our treadmill or run a marathon does not necessarily mean that he or she does not have coronary artery disease. Psychosocial adaptations, something else, as Dr. Hackett mentioned, we have seen very beneficial psychosocial adaptations and have routinely administered a number of psychosocial inventories or tools, the MMPI, for example, being one, which have clearly shown that psychosocial profiles can be improved by regular exercise training. So what are our conclusions? I think it's apparent that sensible, regular exercise, including both static and dynamic forms, is not only safe and effective in selected patients with coronary artery disease, but it does indeed confer numerous physiologic and psychologic benefits which have widespread socioeconomic ramifications. I think although exercise training is widely accepted in contemporary cardiac rehabilitation programs, Dr. Hellerstein advocated exercise training long before it was indeed fashionable. And certainly despite his numerous critics in the early years, he substantiated his beliefs with numerous publications and throughout many professional and public educational endeavors. And for that we thank him.
I think we have time for one question.
It's not really a question, Barry. I think it's important. I fully concur with most of your comments relative to static or isometric contraction. I think that all of our data, I think your data, that's coming from several other laboratories, including some catheterization laboratories, is that what you've said about isometric contraction is fine for the relatively low-risk patient, has been described earlier, particularly, I think, using the criteria of Dr. Knott. But you have patients who on treadmill testing have low functional capacity and poor left ventricular function. That those are the patients who will get into trouble with isometric contraction. I think the sense of effort or the sense of myocardial demand does not show itself, and therefore they have the capability of really overexerting and getting into trouble. Our experience has been that if you have a functional capacity on a treadmill exercise test without any major complication of more than about 6 to 7 minutes, then in those individuals, either arm exercise or dynamic exercise or static exercise doesn't precipitate enough of a myocardial demand to produce ischemia that you haven't already uncovered by treadmill exercise testing. I think that I would just like to add a word of caution that when you said, you did in your slide say selected patients, but you really didn't define that selection.
Bill, I agree with you 100%. I think if we look at the studies that have been conducted, to a large extent, those studies have utilized individuals with high aerobic capacity and good left ventricular function. And to a large extent, we don't know what happens at the other end of the continuum and where the differences begin to fall. So I would agree with you 100%.